So what is the cornea? The cornea is a transparent avascular structure that has a convex anterior surface and a concave posterior surface. So you can consider a cornea like an optical structure that has a function of condensing the eye into the fovea. So this is one of the main refractive medium of the eye. We have two refractive media of the eye. The first one, which is the cornea, which is responsible for 70% of the total refractive power of the eye, while the remaining 30% is the responsibility of another structure. So would you know what, or do you know what is this structure? Yes, that's right. So these are the cornea and the lens together are responsible for the refractive power of the eye. Other functions of the cornea will be the structural integrity. So the cornea to the eye is like a skin to your body. So the cornea, although it is transparent, but this cornea is really tough. So if you experience it to put a scalpel or to make a corneal incision in an intraocular surgery, you will be surprised by how tough is the cornea. So the cornea will be accounting for the structural integrity of the eye, and it will be responsible for many functions regarding the protection of the eye, as we will mention in the physiology. So here is the eye, and we now have a cut section. A cut section of the eye will be revealing this view. So this will be the cornea. This is the anterior chamber, the iris, the lens, the ciliary body, and here are the zonule. In anatomy of the eye, we don't have histology. So we have just what's called the macroscopic picture and the microscopic picture. So in order to study anatomically every organ or every tissue of the eye, we need to know some information about the gross picture and the microscopic picture. So regarding the gross picture of the cornea, we have the cornea is formed from the anterior surface, which is elliptical in shape, with the vertical diameter less than the horizontal diameter. And this is what accounts for what's called the with the rule astigmatism. So being the vertical meridian less than, or the vertical diameter less than the horizontal, making the vertical meridian more powerful than the horizontal, which leading to what's called with the rule astigmatism. And again, this will be discussed in the optics. While the posterior surface is horizontal, so both are 10.7 millimeters. So the posterior surface is like a sphere. The thickness of the cornea is more in the periphery and least in the center. So the thinnest part of the cornea is 0.5 millimeters or 500 microns, and this thickness increased toward the periphery. So it reaches to 0.7 millimeter or even to 1 millimeter at the corneal periphery. And this number is the basic or the basis of all refractive surgery. All corneal refractive surgery are based on this important anatomical fact that the corneal thickness is 500 microns in the center. Radius of curvature of the cornea, which again will be discussed in details in the optics, but just to have this number to know, the convex anterior surface is 7.8 millimeter, and the posterior surface is concave about 6.5 millimeter. This is the radius of curvature, or this is the radius of the sphere that this surface was taken from. And again, this will be mentioned in more details in the optics. Refractive index again will be mentioned in the optics, but just that you know that the refractive index of the cornea is 1.376, while the refractive index of the air is 1 and the aqueous is 1.336. Going more into the corneal details, so we have 5 layers in the cornea. From anterior to posterior, the cornea consists from 5 layers. The most anterior layer is called the epithelium, which consists of stratified squamous non-keratinized epithelium, usually about 5 to 6 layers. This is followed by a tough layer called the Bowman's layer, and this layer is very tough, a cellular condensation of the anterior stroma, while then most of the corneal thickness is formed by stroma. So it's about 90% of the corneal thickness is made by the stroma. Then we come to the desmus membrane. And finally, we then the last structure, the most posterior structure of the cornea is called the endothelium, which is a single layer of hexagonal cells lining the inner surface of the desmus membrane. So here is the epithelium, the Bowman's layer, the stroma, the desmet, and the endothelium. So you can remember them like anterior epithelium, Bowman's membrane, central stroma, desmet membrane, and the endothelium. So it is A, B, C, D, E. Anterior epithelium, Bowman's layer, all the thickness is formed by the central stroma, finally the desmus membrane, and then the endothelium. So in the exam, you are asked about the details of every one of these layers. So let's have a better insight or more in-depth information about the different layers of the cornea, which are the epithelium, the Bowman's, and the stroma, desmet membrane, and finally the endothelium. So the epithelium, as we said, it is formed of 5 to 6 layers of a stratified squamous non-keratinized epithelium. So there will be no keratin over the epithelium, and if there is keratin, this is an abnormal epithelium, and this will lead to loss of the luster of cornea. The thickness of the epithelium, it's about 500 to 600 microns. And again, this is a thickness is important for refractive surgery. So if you know what's called phototherapeutic keratectomy or photorefractive keratectomy, in which we remove the epithelium using either laser or other modalities such as alcohol. So this is if we do laser, so we need to adjust the laser to remove about 500 to 600 microns, which is the thickness of the epithelium. The layers of the epithelium are not equal in distribution or thickness, so they are increasing toward the limbus. As we said, the cornea is more thick toward the limbus, reaching about 10 layers at the limbus. And the limbus is for the epithelium is like it's a progenitor, or it's the source of the epithelium coming from the limbus. So there is specific types of cells present in the limbus are called stem cells. Stem cells are the responsible for regeneration of the epithelium in case of there is any defect in the epithelium, or even without defect, the epithelium usually turn over 7 to 10 days, and this continuous wear and tear is replaced by the stem cells present in the limbus. The epithelium, there are 3 types of cells present in the epithelium. So the most superficial layer is called the surface cells, and the surface cells are more flat cells, about 2 to 3 layers, have microvilli, and the microvilli will have an important role in the physiology of the tear film. We will say that in the physiology. And the epithelium cells or the surface cells are joined together by a specific type of cell junctions called the zonular occludens. And here we come to some important questions in the exam, which is the cell junctions. So cell junctions, we will talk about this in biochemistry. It is like a specific type of cellular proteins that join the cells together. They are different according to their adherence together. So we have some junctions called tight junctions or zonular occludens that makes the cells more adherent together, preventing passage of molecules or become watertight, as we need this function into the epithelium. As in the epithelium, we don't need the tear film to pass into the cornea, as this will impair the corneal transparency. So the zonular occludens present in the surface cells will do this job. The surface cells is later on will be posterior to the surface cells. There will be wing cells. The wing cells layer or the middle cell layer are formed by polyhedral cells. These polyhedral cells have convex anterior surface and the concave posterior surface. And this is the wing, and this is has the deep cells have round nuclei and become progressively flatter upward while it is joined by the epithelium, or while it is joining the surface cells. So these wing cells layer are joined together by zonular occludens in the superficial layer and by another type of cell junctions called desmosomes, which is present more into the deep layers. Finally, the basal layers. So these are the single layer This single layer of tall columnar cells are resting onto the basement membrane, and these tall columnar cells are joined together by the desmosomes, while they are joined to the underlying basement membrane by another type of cell junction called the hemidesmosomes. So again, if you can see this as like two columnar cells, we have the specific junctions between the columnar cells together or the basal cells together. It is called the desmosomes, while the desmosomes are attached to the underlying layer of the basement membrane by like a half desmosome or what's called the hemidesmosome. So is it important to know these facts? Actually, yes. Why? This is because the hemidesmosomes has an important clinical disease. So sometimes we will see this in just a few minutes. So after the base, after the epithelium, there will be the basement layer. So can you hear my voice? Is my voice clear? Okay. After this, after the epithelium, we have the basement membrane. So the basement membrane, if it takes the periodic acid Schiff stain, so it is periodic acid Schiff positive, and it is firmly attached to the Bowman's membrane by anchoring fibrils. So there is no specific cell junctions. It is just anchoring fibrils that attach the basement membrane to the Bowman's membrane. And it takes about 6 weeks for this attachment to be regenerated if it is traumatized. And it is usually this basement membrane is secreted by the basal cells formed by the superficial lamina and formed of superficial lamina lucida and the deep lamina densa. So to summarize, the important cell junctions are the zonular occludens or the tight junctions are between the superficial cells together and between the wing cells. The zonular adherents or the desmosomes are between the wing cells and the basal cells. Hemidesmosomes are between the basal cells and the basement membrane. And this has an important clinical aspect. So, for example, we have a disease called the recurrent epithelial erosion syndrome. What is this disease? Usually, this is a trauma to the cornea. Usually, it is caused by fingernails of an infant or a baby to his mother's eye. So, this will be the common scenario. And the mother will complain of a severe sharp pain in her eyes, especially when she opens her eyes after sleep in the early morning. So, what is the cause of this sharp pain? This is because this child fingernail will cause the trauma to the epithelium, causing loss damage to the attachment of the epithelium to its underlying basement membrane. So the site of the site of trauma or the site of damage will be the hemidesmosomes. So this eye lost her hemidesmosomes, leading to weak adhesion between the epithelium to its underlying basement membrane, leading to a sudden fall of the epithelium causing an ulcer with even slight trauma. So with the slightest trauma like blinking or opening the eyes in the morning, this will lead to sloughing of the epithelium and leading to corneal ulcer. So this usually will improve by repairing or by regeneration of the hemidesmosomes. So to summarize, we have this is the section in the eye, this is the epithelium, and this is the basement membrane, and this is the Bowman's layer, and this is the stroma. So if we magnify the image of the epithelium, we can find that there is a tear film overlying the epithelium. We have the surface cells and the wing cells. The surface cells are joined together by zonular occludens or tight junctions. The wing cells are joined together by zonular adherents and or desmosomes, and the basal cell together are attached by the zonular adherents or desmosomes, while the basal cells and the basement membrane are attached together by hemidesmosomes. And finally, the basement membrane and the underlying Bowman's layer are attached by anchoring fibrils. So is it clear up till now? Okay. So let's move to the next layer, which is the Bowman's layer. The Bowman's layer, it is a thin layer. It is usually about 10 microns that is present beneath the epithelium, and it is a cellular layer, meaning that there are no cells, so there will be no any type of cells like epithelium or whatsoever, but it is formed just from by condensation from the underlying stroma. So the underlying anterior stroma will condense to form the Bowman's layer. The importance of the Bowman's layer that it is resistant to trauma and infection. So it acts as a barrier that prevents trauma and infection to spread inside the eye. So if it is traumatized or if it is injured, this will lead to further rapid spread of the infection. And if it is traumatized, this will lead to scar formation. So the limit between if you have a corneal injury and you wonder whether it will cause opacity or will cause scar formation or not, so check for the Bowman's. If the Bowman's is injured, then there will be scar formation. The problem about the Bowman's layer is that it does not regenerate after damage. So being resistant to trauma and infection, but it cannot regenerate after damage, and this will make a major difference between it and the desmet layer. So the desmet layer will be itself resistant to trauma and infection, but unlike the Bowman's layer, it can regenerate after damage. The Bowman's layer terminates abruptly at the limbus. So we will talk about the limbus today, and we will see what are the structures that was continuous from the epithelium to the sclera, and what are the structures that ends abruptly. Both Bowman's layer and the desmet layer will terminate abruptly at the limbus and will not continue in the conjunctiva. The cornea, the Bowman's layer will contain perforation for passage of the superficial nerve plexus. So just beneath the Bowman's layer is one of the major nerve plexus present in the eye or present in the cornea will be just beneath the Bowman's layer. Then we come to the stroma. So the stroma is again forming the most of the thickness of the eye. So it's about 0.5 microns or 0.5 millimeters or 500 microns, consists of three main structures. So there will be lamellae of collagen fibrils. These lamellae of collagen fibrils are of equal thickness and regularly spaced from each other and parallel to each other, which will are responsible of the refractive power of the cornea. So this regularly arranged collagen fibrils are important for maintaining the corneal transparency. In the anterior cornea, they are more irregular, while as you go posteriorly, they become more regular. On the other hand, there are some certain types of cells, long flat cells with flat nuclei. They are called the keratocytes. These are these cells which secrete the collagen fibrils, and there are other cells called wandering cells or leukocytes and the macrophages. The cells are joined together, or these cells and the fibrils are joined together and maintained in their position by a glycosaminoglycan matrix, which is a mucopolysaccharide formed mainly from the chondroitin sulfate and the keratan sulfate, joining the cells together and the fibrils together and maintain their position. So you can consider the corneal stroma like a soup. So this is a soup containing the meat will be the collagen fibrils, while the spaghetti will be the lamellae. The meat will be the cells of keratocytes, while the spaghetti will be the lamellae of the regularly arranged collagen fibrils. All of them are maintained in their position, and they are joined together and adherent together by this soup, which is the glycosaminoglycan matrix. The desmus membrane, it is a strong homogeneous membrane. So it is strong and tough like the Bowman's layer. But as we said, it is very resistant to trauma and infection. But unlike the Bowman's layer, it can regenerate when injured. So this is the advantage of desmus membrane over the Bowman's layer. It is again the 10 to 12 micron, the same like the thickness of the Bowman's, and this thickness increases with age. So when a person ages, this desmus membrane can increase in thickness up to 5 times. So this desmus membrane increase in thickness 5 times by aging. It is periodic acid shift positive. And when it ages, it will show characteristic excrescence over the desmus membrane. As you can see here are the white dots here and here and here. These are called the Hassel-Henel bodies. So these peripheral excrescence, Hassel-Henel bodies, are just excrescence of the cornea due to aging. Finally, we have a single layer of hexagonal cells, this called the endothelium, has large oval nuclei with the basement membrane. Their apex are in direct contact with the aqueous humor and show microvilli. So microvilli usually are present due to increase the surface of absorption. So this endothelium needs oxygen and needs glucose from the anterior chamber, from the aqueous, and the microvilli will help the endothelium for this absorption. And this will be covered in the physiology. The cells of the endothelium are joined together by the desmosomes and tight junctions, so that to maintain the tight adhesions between the cells and to prevent the entry of aqueous from the anterior chamber to the cornea and maintaining corneal transparency. And the mechanism of regeneration or of the endothelium, that it cannot regenerate. So there is no actual mitosis of the corneal endothelium, but it can compensate for any defect by what's called pleomorphism and the polymorphism. Pleomorphism meaning that the cells increase in size, change in shape to compensate for the defect if there is lost endothelial cells, and the polymorphism meaning that the cells increase in size to compensate for the defect. So polymorphism and polymorphism are the mechanism that in which the endothelium compensate for the endothelial loss. Well, so we have the epithelium, we have the boomers, the stroma, the desmet, and the endothelium, and this was our understanding for the corneal anatomy until few years ago. A few years ago, there was a new layer discovered in the cornea called the Dawes layer. The Dawes layer has revolutionized our understanding of the corneal anatomy, and because it was discovered by the Harminder Dawa. So Harminder Dawa did a electron study of electron microscopy study of the cornea and discovered that the last 10 or 20 microns of the cornea are different histologically than the remaining stroma of the cornea. So it's called, he named it after his name. So it's called Dawes layer. And this layer has an important or made a breakthrough in the lamellar corneal surgery. So this will be made a huge difference in the corneal lamellar surgery by identifying that there is a layer, what's called the predesmatic layer or Dawes layer, just at the end of the stroma or just in front of the desmus membrane. Okay, so at the corneal periphery, so here is the cornea and here is the conjunctiva and the sclera, and this is the junction between the cornea and the conjunctiva and sclera, which is called the limbus. And at the limbus, the Bowman's layer and the desmus membrane, both of them end abruptly. So there will be no Bowman's layer and there will be no desmus layer after the cornea end. Again, this is an important and asked frequently in the MCQs. So the Bowman's layer and the desmus layer both end abruptly and they don't continue into the corneoscleral limbus. Blood supply of the cornea itself is avascular. So they should be, or the cornea should be avascular to maintain its transparency. However, the cornea or the limbus is the one which has received blood supply from the conjunctival branches of the anterior ciliary arteries. So here are the anterior ciliary arteries. They give conjunctival branches that will supply the limbus. And this is what will be responsible for the ciliary injection, circumlimbal ciliary injection. So if the cornea is avascular, how can the cornea acquire its nutrition? So this will be by acquiring the nutrition from aqueous behind it, from the tear film in front of it, from the limbal capillaries outside it. The cornea is very rich in nerve supply, so it is supplied mainly by the trigeminal nerve. So the trigeminal nerve will give the ophthalmic nerve, and the ophthalmic nerve will give the nasociliary nerves, which will give split to form the two long ciliary nerves that will pass into the suprachoroidal space and the supraciliary space to reach the anterior segment of the eye. So again, the nerve supply of the cornea comes from the trigeminal nerve. The trigeminal nerve will give the ophthalmic nerve. The ophthalmic nerve will divide into the nasociliary nerve. Nasociliary nerve will give the long ciliary nerves. That the long ciliary nerves will perforate the eye at 3 and 9 o'clock and pass into the suprachoroidal space, supraciliary space until they reach the anterior segment of the eye. When the medial long ciliary nerve and lateral long ciliary nerves reach the cornea, just before they reach the limbus, they form what's called the pericorneal plexus. So the pericorneal plexus are formed by the long ciliary nerves and in conjunction with the conjunctival nerves. So the ciliary nerves are joined together with the conjunctival nerves, forming the pericorneal nerve plexus. And this has again an important clinical or surgical consideration in LASIK surgery. So in LASIK surgery, we pass a microkeratome, which is like a form of surgical knife that will cut a flap into the cornea, and then we will raise this flap and put the laser and deposit the flap. So when the microkeratome or this surgical knife cut into the cornea, this will lead to cutting of the corneal nerves. This cutting of the corneal nerves will lead to that the patient will experience a dry eye usually after the surgery, and this dry eye can take up to 6 months to be resolved in most of cases. This is because of regeneration of corneal nerves, which takes up to 6 months. From the precorneal nerve plexus, they travel for 2 to 3 millimeters and lose their myelin sheath. This is important. So they travel into the cornea for 2 to 3 millimeters and lose their myelin sheath, so that the cornea should have or should receive non-myelinated nerve fibers. And this is important because, again, for transparency. If the cornea has myelinated nerve fibers, this will not be good for transparency. Then the corneal nerves will be divided into anterior group and posterior group. So the anterior group will be forming a plexus beneath the Bowman's layer here. And then there will be another posterior group will supply the posterior stroma.